Bismillahirrahmanirrahim. It's me, Dr. Naseem Chirzad, and today I'm going to discuss with you all the cryptorchidism or undescended testes. Uh, Undescended testes is one of the commonest surgical problem in male at pediatric surgery clinic, and the cause of cryptorchidism is multifactorial and it exhibits a wide variation in phenotypic expression. And the word cryptorchidism is a Greek word and it means hidden testes. So it can be retractile in 65% of cases, it may be undescendant in 35% of cases, and it is ectopic, not in their normal pathway of descent in 3% of cases, and it is ascending in less than 2% of cases. Ascending means the testis which was initially in the testis but later on it again ascended, which is also called acquired UDT. And now coming to the causes of these UDT and the various prevalence. UDT in full term patient present in 1 to 3% of cases, but the prevalence of this cryptorchidism reaching to 30% in premature male neonates. Approximately 80% of the undescended testes are palpable, and 60 to 70% are unilateral. And it is important that it is most commonly on the right side, and the reason is that on the right side the testis is present during the embryological period above, and that's why when we are seeing there is asymmetry in the testis, the left is downward hanging as compared to the right one, and 20% of the testes are non-palpable. Now coming to the differences between the retractile testis and a gliding testis. A retractile testis can be brought into the scrotum and when released remain there for a time, while a gliding testis will only come down under tension and are the traction required to pull it down, causing the pain. So a retractile testis does not require usual surgery, while gliding testis require the surgery. That's why we observing the patient of retractile testis till adulthood type, and the reason of this retractile testis because of the hyperactive cremasteric reflex. Now coming to the difference of vanishing testis and that of agenesis. So vanishing testes are those which are initially present in their development but are lost owing due to some vascular accident like testicular torsion. So in vanishing testes, the testes initially present in the development, but they are lost due to some muscular accident like testicular torsion. It can be unilateral or bilaterally. While the testicular agenesis mean that the testis was never present and therefore associated with ipsilateral Mullerian duct persistence. So in agenesis, there will be present of ipsilateral Mullerian duct, while in that of vanishing testis, there will be no presence of Mullerian duct, and that is initially present, while agenesis testes are not present initially. And what about the ectopic testes? Ectopic testes are those which are not present in their normal pathway, means the testis which is away from the normal pathway. The commonest location of the ectopic testis is that of superficial inguinal pouch, which lies anterior to the external oblique epineurosis. It can be located in the perineum, interior to the root of the penis. It can be present in the femoral triangle in the upper thigh, and it can be present in the contralateral scrotum, and it can be present within the interior abdominal wall. So these are the various locations for ectopic testes. And now it is also important to understand the embryological basis of testicular descent. There are two phases of the testicular descent. The one which is occurring by the 12-week or 3 month of gestation, and that is under the influence of Mullerian inhibitory substances MIS, and it reach to the deep inguinal ring. The second phase or second descent at that which is occurring in 25 or 3rd week of gestation, means at the 7 or 9 month of gestation, and that is under the control of testosterone reaching into the inguinal canal and then into the scrotum. So this is the embryological basis of undescended testes, or we can say the normal descent of the testes. And the anatomy of the testis is also important. The blood supply to the testis is 9 ml per 100 milligram per minute of the testis, and their testicular supply is also important. The main arterial supply to the testis, that is from testicular artery, which is also called internal spermatic artery, and that is the main branch and main supply that is arise directly from the aorta. The vas deferens artery, which is also called the differential artery, and it is a branch of superior vesical artery, and superior vesical is a branch of internal iliac artery. The third is the cremasteric artery, which is also called external spermatic artery, and this is a branch of inferior epigastric artery, which is in turn the branch of the external iliac artery. And the normal diameter of the testis length to width ratio is 4 to 5 centimeter, and normal volume is 20 to 26 ml. And the layers from outer to inner include the tunica vaginalis, the tunica albuginea, and the temperature around 2 to 4 degree lower than the body temperature means the testicular temperature is around 37 degree, 33 degree, 33 to 35 degree. Now if a patient present to you with undescended testes and you are planning for archaeopexy, but the parent does not like the idea of operation, and they ask you why you are considering that should be corrected. So you can explain the various reasons of this surgical correction, like number first, to preserve the fertility. Note that later paternity rate are 80 to 90% if the patient has unilateral inguinal archaeopexy. Because of the increased risk of malignancy, which may be as high as 10 times than the normal risk, bringing the testis into the scrotum will most importantly allow the boy to perform testicular self-examination when he becomes at risk after puberty. There is now some evidence to suggest that archaeopexy may reduce the risk of germ cell malignancy. The other important factor is the cosmosis. The undescended testes are at high risk of torsion. Archaeopexy would abolish the small risk of hernia arising from patent process vaginalis that is often present. So you would explain these things to preserve the fertility, to decrease the risk of malignancy, means in the sense that there will be the patient will be able to perform testicular self-examination at puberty. There will be less risk of torsion, and there will be risk of hernia. Because of these reasons, you can counsel the parent regarding the surgical correction of undescended testes. And now if the parent of the patient is ready for surgical correction of archaeopexy, then how to explain to the parent that what will be done during procedure. So you will explain like this, that an impalpable testis require that treatment decision will have to be taken in the operating theater, because the decision of impalpable or undescended testis is to be done under general anesthesia. So an examination under anesthesia is performed when the child is asleep and relaxed. Assessment can be easier, and it may be possible to locate a previously impalpable testis in the groin. So it is very important when you are planning for the surgery, your first intention is the examination and under anesthesia. As when the patient is not relaxed, you may be unable to identify the testis in the inguinal region. But if the patient is relaxed under anesthesia, it is possible that the testis may be palpable in the inguinal region. So you will explain to the parent this scenario. Now, if the testis is palpable in the groin region, then simply go straight forward for inguinal archaeopexy. Now, if the testis is impalpable under anesthesia, then immediate laparoscopy is performed to look for intra-abdominal testis. So that's why under general anesthesia, first to examine the patient. If it is palpable in the groin, then go straight forward for inguinal archaeopexy. And now if the testis is not palpable, then we can go for diagnostic or therapeutic laparoscopy. Now, various scenarios can come on going through laparoscopy. If an intra-abdominal testis is found, then laparoscopic archaeopexy is performed. If the testis is close to the inguinal ring of the inguinal canal, then it may be possible to do this as a single stage procedure. However, a higher testis will require the first stage of two-stage of Fowler-Stephan procedure. The testicular artery is divided, leaving the testis to survive on the artery of the Bose, which is a branch of the inferior vesical artery. The second stage is performed after 6 months, and it is used to mobilize the testis into the scrotum. This stage operation carry an approximately 20% risk of testicular loss. So it's important to explain the parent that there is a risk of 20% loss of testes in the second stage. So in first stage of Fowler-Stephan arteriopexy, the testicular artery is sacrificed, and the rationale for that testicular artery is that the testicular arterial supply is actually coming from three sources, which we have already discussed, that it coming from testicular artery, the cremasteric artery, and the vas deferens or differential artery. That's why we can sacrifice the testicular artery. At second stage, which we are performing after 6 months, but it is important to explain to the parents that there is a 20% risk of losing of testes in second stage. Now, another scenario, if there is a vessel and especially the vas are blind ending or end in a poor nobium of a tissue, a diagnosis of vanishing testes is made. Now, the nobium of tissue should be removed. A possible explanation for this vanishing testes, which we have already explained, that may be because of testicular torsion. For this reason, it is worth considering to perform an arteriopexy on the contralateral testes to prevent that one undergoing torsion. So if there is a vessel and especially the vas are blind ending or end in the poor nobium of a tissue, so the diagnosis of vanishing testes to be made. Now another scenario is coming if the testis has been impalpable, but vas and vessel are seen entering the internal inguinal ring, then the subsequent decision is controversial. Some would argue that if the testis is found, then they usually don't contain a germ cell, so they are not at risk of malignancy and therefore nothing further need to be done. One would have to be confident of examination finding to be certain that an ectopic testis or an inguinal testis and more chubby boy had been missed. So it is important if the testis has been impalpable but the vas and vessel are seen entering the internal inguinal ring, to decision either it to go for archidectomy or is it having no germ cell, so leave it as a such. So this is the explanation to be given to the parent. Now what are the other two important consideration if you want to bring the testis into in a second stage, but you are facing the problem of you are unable to bring into the testis, so you can apply the Prentice maneuver, which is actually dividing or passing the testis under the inferior epigastric artery, just like at the inferior epigastric artery, or pass the testis under the inferior epigastric artery by opening the floor of the canal, means the transversalis fascia, and this will allowing a more medial and thus a more direct route to the scrotum. So this maneuver can be applied. In some condition, microsurgical autotransplantation can be done. Just cut the artery and then transplant with some artery at the scrotum. So this maneuver can be done. And the second maneuver, the cranial extension of the incision, just incise, extend your incision in the cranial direction. And the third, we can go for dissection of the retroperitoneal attachment of the cord, and then can also give us some length. So these are the various maneuvers to gain sufficient length during arteriopexy. And what are the steps of inguinal arteriopexy? As we have already mentioned, that examine the patient under anesthesia to confirm the position of the testis. If you found the testis in the inguinal region, then go for a crease incision just 2 centimeter by the pubic tubercle and 2 centimeter lateral to the pubic tubercle or just near to the pubic tubercle. Then open the external oblique to get access to the inguinal canal. Identify the testis. Divide the gubernaculum, taking care not to injure vas that may be looping below the testis. Separately laterally bend that may be fixing the testis close to the inguinal canal. The most important step is to carefully mobilize the vas and testicular vessels from the process vaginalis. Once this is free, this process vaginalis is transfixed and divided at the level of the internal inguinal ring to prevent future hernia, and then mobilize the vas and vessel to gain length. Create a dartus pouch. A dartus pouch is actually located between the skin and dartus fascia. So we putting the testy in that pouch, which is called actually calling the subdartus pouch, but it is at the outside of the dartus fascia, means this between the skin and dartus fascia, and then close the wound. So these are the step up. And what are the risks of inguinal archidopexy? It can be intraoperative, early operative, and late operative. Bleeding, infection, wound complication, unable to bring down the testy to satisfactory position. Testy lateral ascent, this is an iatrogenic ascent where scar around the card hold at fixed length so that the testy is pulled as the boy grow. And approximately 5% risk of injury to the testicular vessels or vas. And what is the concept of hormonal therapy? So according to 2023 AU guideline, they are saying that hormonal therapy per unilateral UDT is of no benefits for future paternity. Upper endocrine treatment in case of bilateral UDT, and the role of hormonal treatment is diagnostic to differentiate a truly UDT from erectile testy. And one of the important thing that is the workup. For unilateral undescended testy without hypospadias, no laboratory tests are needed. But for unilateral or bilateral undescended testy with hypospadias, a karyotyping for ruling out intersexuality is important. And regarding MRI, this is optional. There is no need of MRI in children as it cannot be done without GA, and it is not 100% accurate. You can go for MRI in adult. And it is important that patient should not be operated before 6 months because there is a chance that it will descend in the first 6 months of life. So this was all the detail about the undescended testes.